اتفضل ابدا يا دكتور عثمان.
انت دلوقتي يا باشا.
خلاص ايه.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد النبي الأمي وعلى آله وصحبه وسلم أجمعين. بسم الله الرحمن الرحيم. Welcome everyone. Thank you for joining us for today's webinar. Dear colleagues who are virtually connected, welcome to our webinar organized by Academic Affairs SGH Asir. It is my great pleasure. I am Adil Osman, neurologist at SGH Asir on World Equality Day 12/11/2020 to be a chairman of this interesting event within the framework of our great organization, aiming safe and high quality medical service according to the most latest evidence-based guidelines. Today we are presenting acute management of ischemic stroke. Have two lectures, one lecture by Dr. Adil Hazzani, thrombolysis in acute ischemic stroke, and the other lecture by Dr. Sultan Al-Qahtani about mechanical thrombectomy with acute ischemic stroke. We would like to hear from all of you. If you have any question during the presentation, please type them into the question box. I will bring them up during the presentation, and we will also have time for a question at the end of each lecture. I'd like to introduce the first presentation with Dr. Adil Hazzani. Dr. Adil Hazzani, Associate Professor of Neurology, College of Medicine in King Saud University, consultant neurologist, interventional neuroradiologist at King Khalid Hospital, Riyadh, and the Prince Sultan Military Medical City. He is immediate past president of Saudi Stroke Society, Secretary General of Saudi Neurology Society, board member of National Stroke Clinical Advisor Group, member of Scientific Board, member of Examination Council for Saudi Neurology Board. He is consultant at Saudi Central Board for Accreditation of Health Care Institution سباهي. Most welcome دكتور عادل الهزاني. دايما الدكتور عادل الهزاني بيتحفنا زي ما بقول بالاوركسترا بتاعته، يعني عازف الاوركسترا، ربنا يبارك فيه.
بسم الله الرحمن الرحيم. مساء الخير. Thank you, Dr. Adil, for this kind introduction and for your kind invitation. It's a pleasure to be here with you with this elite group and to be with Dr. Sultan Al-Qahtani, who's a mentor and inspiring colleague, to talk about the acute ischemic stroke management, and I'll talk in particularly about thrombolysis. Can you hear me?
Yes.
Okay. So I'm trying to advance my slides. This is the overview of my presentation. We'll talk briefly about stroke in general. Then I'll talk about the concepts of treatment of acute stroke. Then we'll talk about the evidence for IV-TPA and some of the landmark trials by which we reached to where we are today. We'll talk about some special consideration and limitation of IV-TPA, and then we'll talk about conclusion. I have no conflict of interest related to this presentation. I noticed that my presentation goes slow when I'm in camera, so I'll just switch it off and go from there. Okay, so when we talk about stroke in general, so stroke is defined as an abrupt onset of focal neurological deficits due to interruption of vascular supply. Stroke can be ischemic due to blockage of the blood vessels or hemorrhagic. Most common type is ischemic, which represents about 80% of all stroke, and then the hemorrhagic represents the other 20% or so. The burden of a stroke worldwide is huge, and the societal impact is tremendous. So when we talk about stroke for our junior colleagues, we talk about numbers 1 to 6. So number 1, stroke is the leading cause of adult disability. It's the second leading cause of dementia following Alzheimer's disease. And in Saudi Arabia, it's the second leading cause of death following cardiac disease. It's the third leading cause of death worldwide following malignancies and cardiovascular diseases. Each year, there will be 20 million people suffer a stroke, and about a quarter of those, it will lead to death. So last year, the World Stroke Organization in the Stroke Awareness Day used the theme of 1 in 4. That is, 1 out of 4 people might suffer a stroke during their lifetime. And as I mentioned earlier, it results in 5 million deaths every year. And every 6 seconds, somebody will die from a stroke around the world. In the kingdom, every 15 to 20 minutes, somebody is developing a stroke, and every 1 to 1.5 hours, somebody might have died of a stroke around the kingdom. If left untreated, stroke is bad disease, so only a quarter of patients will have a full recovery. The other will be disabled at different degrees, and in half of the patients, the disability will be severe, limiting their activity of daily living, and it might result in mortality. In Saudi Arabia, the incidence of stroke is estimated of a first-time stroke is 57 per 100,000, and if we include recurrence, it's going to be 70 victims per 100,000 population. So this comes to 20,000 new strokes every year, and if you include recurrent stroke, it will be 25,000 every year. Unfortunately, the majority of those patients, they don't receive the standard of care. So only 5% of those stroke patients admitted to specialized stroke units. Less than 5%, around 3.3%, receive the IVTPA, and there are less than 200 thrombectomies done annually. Now, those numbers are about 2 years old. This is the work of our colleagues in KFMC, Dr. Fahmi Sinani and Dr. Al-Jahani, and I was privileged to be part of this work. So there is a lot needs to be done to improve the outcome in those patients. It's expected that the numbers of strokes will increase by 50 to 60% over the next 10 years or so. And this is how stroke looks like. If you're following the US elections, which still it's concluded and we're not sure about the results. This is Ron Paul, who is a physician, writer, and politician, and he was a presidency candidate. This was an interview a couple of weeks ago. So this is what strokes looks like.
It has to be liquidated. We have to get rid of that. That's a burden. We're just kind of
So stroke is sudden. You've seen started to have trouble speaking with asymmetry of his face. So this is the bad side. Stroke can affect anyone, anytime, even young people. 25 of strokes would happen in a young.
It has to be liquidated.
Good news is that stroke is treatable. This is the very same person 2 days afterwards, and he's able to move his affected side, and he's able to smile, and you can see his face is symmetrical. So stroke can be effectively treated. There are 2 ways of treating it: through IVTPA, dissolving the clots, or through mechanical thrombectomy, removing the clot. Now, my talk is going to be around the IV thrombolysis, and I'll leave the mechanical thrombectomy to the expert, Dr. Sultan. The concepts of treating ischemic stroke relies on what we call ischemic penumbra. As you can see in this diagram, when you occlude the right middle cerebral artery here, there will be part of the brain that doesn't receive enough blood supply and doesn't have a good collateral flow. This part will go into an irreversible injury or an irreversible cell death. We refer to this as a core. But usually there is a surrounding areas which is bigger. This surrounding tissue, it will be functionally impaired, it will stop functioning, but it's still salvageable. This will be based on your collaterals, and this will be salvageable for a short time. So most animal studies and lab studies, it showed that the penumbra could persist for a few hours. And as I said, this is dependent on your collaterals. So the longer you wait, the more penumbra will recruit into core, and then you will have an irreversible damage. So you need to be quick in your interventions to restore the flow. And this has been demonstrated nicely by the work of Jeff Savers and his colleagues, where they studied how many neurons are lost to large vessel occlusion. And every minute passed in a large vessel occlusion in the brain losing 2 million neurons, 14 billion synapses, and it resembles aging by 3 weeks. And of course, if you wait longer, this numbers keeps multiplying. So you lose 120 neurons 830 billion synapses, and it's as if you're aging 3.6 years. So faster restoration of the flow or faster reperfusion, it's associated with better recovery, and you will hear me again and again emphasizing on these concepts during my talking. Every minute you saved in reperfusion, it's equivalent to adding 2 days of healthy living, and every 15 minutes it's equivalent to adding 1 month of healthy living. So indeed, time is brain. The new era where our intervention in stroke changed from hopeless situations to more of a treatable medical emergency was back in 1995. So this is 25 years ago. And this was just celebrated the 25th anniversary. So TPA is not a new news or something, new interventions. It's been there, and the evidence been there for 2.5 decades, with the publication of the famous NENS trial, where they took more than 600 patients and they divided them into placebo versus IV TPA, and they looked at the outcome in 3 months, and you can see higher percentage of patients receiving the IV TPA had an excellent outcome compared to those in blue who were in placebo. And the IV TPA increased the odds ratio for favorable outcome by 1.7. So for the first time, we started to have treatment for stroke, and now neurologists, even lifestyle change, and the way we look to stroke is a change. This is the inclusion-exclusion criteria for this study, and I know it's a busy list, but I don't want you to remember all of this, but I need to mention that those criteria came by consensus. So in order for you to be part of this study, you need to be an adult coming within 3 hours, so known onset, and then you have a clinical diagnosis with measurable neurological deficits. And then there are contraindications basically around the decreasing risk of your bleeding. So anything would make you at risk of bleeding, high blood pressure, if you have coagulopathy, or if you have a recent surgery or head trauma or MI. And as I said, this was an agreement or consensus between the investigator of the studies, and from the literature we know from the cardiac disease. Now, if I try to put the data in more visual form, if you treat 100 patients with TPA in the first 3 hours, represented by the graph to your right-hand side, about a third or 32 of those patients will improve across the scale. So if they have severe, they'll improve to moderate. If they have moderate, they improve to mild disability. But among those, there'll be 13, they'll be back to normal or near normal. They'll be completely independent. So the number needed to treat for any benefit is 32. This will be an expense of 3 patients who will be harmed. And the risk of hemorrhage with an NENS trial was 6%, but only half of those patients, the hemorrhage will result into neurological deterioration. So this is represented here by the graph by the 3%. And one of them, it might be leads to severe disability or death. So number needed to treat is 3 for any improvement and 7 to be completely independent. This is for the first 3 hours. It's been proved to be safe even in community studies that was done in Europe and US and Canada. And the effectiveness and safety was similar to the NENS trial. It's proven to be cost effective. In US, if you treat 2% of your population or patients coming with stroke, with TPA, the hospital or the institute will save 2 million every year. And it's estimated that in every patient treated, you're saving somewhere between 3 to 10,000 US dollars or euro, depends where you are. So it is safe, effective, and also cost effective. It's becoming the standard of care. However, it was still underutilized, as I show you, until nowadays. It's the usage of TPA in stroke patients, it doesn't exceed 5% globally, and it's more around 2 to 3%. One of the reasons for that is the long contraindication list and the short time window. you compare the efficacy of TPA to PCI, which is the standard of care that our cardiologists are doing, it's actually compared more favorably. As I said, the number needed to treat for any improvement is a 3, and it's around 7 to 8 for being completely independent, while PCI, the number needed to treat is 17, and it's 34. And TPA for or thrombolysis for MI, the number needed to treat is somewhere between around 30 to 40. So it is even more effective than the thrombolysis or PCI for MI, yet it's not used as much. One thing that was looked at through this pooled analysis of all IV TPA trial, putting the data of all patients receiving TPA in the first 6 hours or thrombolysis in this landmark studies. And we noticed two things. One is that the effect of TPA is time dependent. So the earlier you treat, the better. So the odds ratio for favorable outcome if you treat in the first 1.5 hours is almost approaching 3. And this benefit or efficacy is decline with time, but it doesn't reach the 1 or lose benefit until up to 4.5 hours. Now, this observation was noticed, and it needs to be further tested, and it was tested by the ECAS-3 trial, which was published in 2008, where they looked into effect of TPA between 3 to 4.5 hour window. In particular, this is the extended window, but here they excluded. Had additional exclusion criteria. So they excluded patients older than 80, or they have here, if they have a severe stroke, either radiologically or clinically meaning NIH stroke scale more than 25, and they excluded patients who had combination of a stroke and diabetes, or if they've been on oral anticoagulation regardless of their INR. And in spite of treating patients at a later window, now we're talking 3 to 4.5 hour window, still TPA was effective. There was more excellent outcome seen in half of the patients compared to 45% on the placebo. Even mortality, it was less in the treatment group. However, this was not statistically significant. And then the symptomatic hemorrhage here, although we're treating late, it was only 2.4%. Now here, they use symptomatic hemorrhage. So you have to have hemorrhage and neurological deterioration compared to the NENS trial. The number needed to treat is 14 to be completely independent for excellent outcome, and 7 for any improvement across the disability scale. This is what happened in reality, and I like to bring this graph because this is what I see in the hospital. When the window was extended to 4.5 hour window, the ER system or the emergency become more relaxed. So if you can see the x-axis, this is the time patients takes to present to the hospital, and in the y-axis is the time we take to treat those patients. And as you can see, when patients presented in the first 1 to 1.5 hours, actually it took longer time to treat them because they were relaxed. We have 4.5 hour window. When they come late, all those patients were able to treat within the 1 hour. And this is the wrong message. Every patient should be treated as soon as possible. The extension of the window to give a chance to treat more patients, but it doesn't mean that you should be relaxed, that you had more time to treat this patient. So time is brain. That's why the guidelines specifically mentioned that door to treatment should be within 60 minutes for all patients, and this has the highest grade of evidence. So you need to be efficient and quick. Because as we said, the number needed to treat, if you treat in the first 1.5 hours, is 3 to 4. The number needed to treat between 1.5 to 3 hours is 7 to 8. This is for excellent outcome. And between 3 to 4.5 hour window, it's double that. So it's not only the number needed to treat decline with time, increase with time and less patient benefit, but also risk of complication. As you can see with the red parts, it actually increases. And after 4.5 hour window, you have a reverse ratio where you do more harm than the good. Following that, a couple of trials were published. One of them is the IST, and then this pooled analysis, which includes data from 12 trials. And the reason why I want to bring this data is that it shows that this is the largest trial, and it shows that IV TPA within 3 hours from symptoms onset increased the odds ratio of being alive and independent by 50%. So you have 50% chance to be alive and independent. This is regardless of your age. So age is not contraindication. And as you can see, whether you're less than 80 or more than 80, even in the extended window, those patients benefit regardless of your NIH stroke scale. Even very, very severe strokes, they still benefit from IV TPA. So, and then treatment delay, you can see it's more effective. It's used within the first 3 hours, still effective up to 4.5 hours, but in general, if you start treating more than 4.5 hours, it starts crossing the confidence interval, start crossing the ones to losing the benefit. This is a very interesting data that was published from in the stroke last month from our colleagues in Alberta, in Canada. And what they did, they looked, at the province level, regional level, they try to cut the door to needle time. So they treat patients earlier. They still doing everything else the same, but they dropped the door to needle time from 70 minutes to 40 minutes by being more efficient. And just only by doing that, 60% of their patients were discharged home independent. So they increased their percentage of patients going home from 45% to 60% just by having more effective systems to deliver the TPA. And this is at a regional level. And I would also invite you to look at this American Heart Association, American Stroke Association statement, looking to the updated contraindication list, where a lot of the contraindication we used to have eliminated. For example, patient with rapid improvement, or if they have seizures at the onset, hyperglycemia, severe stroke, elderly. So a lot of those changes, a lot of those contraindications were removed to expand the use of IV TPA safely and judiciously. What we need to do is weigh benefit and risk. As we said, benefit is recanalization and clinical improvement, but there are risks of bleeding, as I mentioned, clot migration, allergic reactions, and angioedema. And we can predict the risk of hemorrhage by looking at different measures or scales. I like to use the SITS scale driven from the SITS registry. And basically, the higher the number you have, the more risk of bleeding. So the more severe your stroke risk, if your glucose is high, if your blood pressure is high, if you are obese, you add points for each one of those, and then you look at the risk of hemorrhage. However, even if you have all those points, your risk of hemorrhage doesn't exceed 10%. I just need to mention, if you are on dual antiplatelets, aspirin and Plavix, you add 3 points. So being in dual antiplatelets, it makes you at a higher risk of bleeding. Now, you need to be careful. Those are not contraindication. You need to use this to evaluate risk and benefits. So if somebody is dual antiplatelets, it doesn't mean you should jeopardize them and not giving them thrombolysis if they are eligible. But this is how to weigh risk and benefits. Now, all those factors, you cannot do anything about it. You cannot do anything about the way patient presented or how high was their blood pressure. But you can change the time they needed to treat it. So again, door to needle, treat them as soon as possible. Now we'll talk about the limitation of IV TPA. One of the biggest limitations of TPA, it doesn't work as well if you have a proximal occlusion. So if you have, for example, T occlusion, risk or the chances of recanalization, it doesn't exceed 10%. So it's between 4 to 8%. In the proximal MCA, it's 1 in 4, so it's around 24, and in optimistic data, it's around a third. And then distal, it has higher chances of working. So the more distal occlusion, the better chances for TPA. The other thing is the length of the clot. If the clot is more than 8 millimeters, the chances of having recanalization is less than 10%. And also, if you have a solid clot, if you don't have any permeabilities of the contrast through the clots, it means it will be resisting to TPA. And in the opposite, if you have a permeable clots or pervious, it's more chances to work. Because of the limitation of the TPA, the intra-arterial routes become more available and more interesting to treat those patients with large vessel occlusion. And in 2015, six positive randomized controlled trials came, and it was published in the New England Journal of Medicine. It was the era of mechanical thrombectomy that we started to show the evidence. Now, it was performed for at least more than a decade, but we were waiting for randomized controlled trial data. And with that, as I said, I'll leave the details of this discussions to Dr. Sultan. But a question often came is, okay, the mechanical thrombectomy now is very effective in opening vessels. So if you have somebody with large vessel occlusion, do we still need to use IV TPA? The pros and cons for that is adding TPA, it adds to the cost, and they might be theoretically delayed for infusion, and you're exposing patients to risk of hemorrhagic transformation intracranially or systematically. On the other side, using TPA, it might, as I mentioned, although it doesn't work as well for large vessel, but in large vessel occlusion, about 10 to 15% by the time they go to the angio, and we see this in daily practice, they have recanalization and you don't need the procedure. If you have distal embolization that's not accessible, it's good to have IV TPA. And sometimes you have patients with very difficult access. Having IV TPA is better than nothing. Now, I need to mention that nearly all of the mechanical thrombectomy trials included patients with IV TPA in the highest percentage. Some of the trials like Extend IA, 100% of the patients had mechanical thrombectomy on 10 of IVT on top of IV TPA, and the others, between 70 to 90% of the patients received IV TPA when eligible. So those they did not receive TPA, those were ineligible to IV TPA, for example, due to recent surgery or coagulopathy. And in meta-analysis that we've done, it showed that percentage who had of patients who had IV TPA and mechanical thrombectomy did slightly better than those who had the mechanical thrombectomy alone. This was also demonstrated by the Hermes group looking on all the mechanical thrombectomy trials, where they noticed that patients who receive IV TPA had less distal embolization and less strokes in other territory. So based on that, we still, if patient is eligible for IV TPA, you should start infusion, but this should not delay you from going directly to mechanical thrombectomy. So you start infusion, you don't wait for response, and you proceed with mechanical thrombectomy. Now, I'll talk briefly about the expansion of the window for acute ischemic stroke. Now, I used to give those slides as some of the future directions, moving from time window to tissue window. But now we have the evidence for this, and this is becoming the standard of care for extending the window with the publication of Mr. Witness trial. Now, I need to mention about 20 to 30% of patients, they would come as a wake-up stroke or unclear onsets. And those patients, if you go by rigid or conventional definition, you wouldn't give them TPA. But what they did in Mr. Witness at the Mass General Hospital by Lee Schumann is they took those with wake-up strokes or unclear onsets, and they did MRI. They look for what we call diffusion flare mismatch. So if you have flare, if you have DW lesions, but you don't see it in the flare, then you are most likely that stroke happened in the past few hours, and they treated patients with IV TPA. And this was an open single arm trial, open label, and there was a higher percentage of the patients had favorable outcome approaching 45% compared to historical control from the NINS trial. And then two trials were published using what we call MRI perfusion or DW flare mismatch, and the other one we kept used special perfusion imaging, looking at the penumbral imaging, and both demonstrated benefit of TPA in selected patients in the extended window. Now, just 2 days ago, this is a very updated slide. They published this study. It was published in Lancet, and they presented it in the European Stroke Meeting, World Stroke Meeting, where they included the meta-analysis and individual patient analysis from 4 trials, looking at the extended window in the patients of unknown symptoms onset due to wake-up. And it showed the benefit of IV TPA in those selected patients based on perfusion imaging. There was an additional 8% compared to placebo had excellent outcome. I need to mention that quarter of those patients had LVO. So the implication for that is if you have somebody in a remote area, for example, in Saudi Arabia, in Ar'ar, or in Najran, where they don't have access to mechanical thrombectomy, you could use this data to help those patients. At least it's better than nothing. And now, based on the publication of this study, we have level 1 evidence to use perfusion imaging to extend the window in patients with wake-up stroke or unclear onset of the stroke. Special consideration, if you have somebody with mild non-disabling stroke, data from PRISM showed that this patient, maybe you should avoid TPA. So if you have somebody with only sensory symptoms or face only or mild dysarthria, it's better to go with medical management because you might increase risk of hemorrhage without added benefit. One trial came from Asia, Enchanted, looking at lower dose of TPA, 0.6 milligram. And there was no evidence that it was as effective as the standard dose, but the risk of hemorrhage was less definitely on this dose. As I mentioned earlier, even if you plan mechanical thrombectomy, even with the publication of recent two trials from Asia, still you should give TPA for eligible patients, and then you go for mechanical thrombectomy until we have the data from the trials that's going on. If TPA is not available or alteplase, TNK is a very promising alternative. It's giving as a bolus, it's quicker, and it's more effective even if you have large vessel occlusion. So this is a tip because it's also available in Saudi Arabia. And I think this will come into the guidelines. And with the COVID, people start using TNK more frequently in US and in Europe because it's given as a bolus. So there is less contact with the patient. So with that, I hope I'm concluding here. I hope I was able to show you that stroke can be effectively treated. The window for treatment is short. The earlier you treat is better. IV TPA is a gold standard for up to 4.5 hours ineligible patients if they don't have large vessel occlusion. The earlier you treat, the better. Beyond 4 hours, if you want to extend the window or when wake-up strokes, you need to have perfusional imaging, either using CT perfusion or MRI. TNK is a promising alternative, and we should work all together more to increase access of the patients to this treatment. With that, I would like to thank you, and I'll be happy to take any questions.
Thank you, Dr. Adel Hazani, for your comprehensive lecture. Now we go to a question for Dr. Adel Hazani from anyone. There is a question about wake-up stroke, but you talk about it.
Yeah, I mean, the key message is we should find the reasons to treat the patients, not to withhold therapy. So if they have a wake-up stroke and they have, and if you have access to MRI, then you would take them quickly to the MRI, look for diffusion, DW, flare mismatch, and if there is a mismatch, you should treat those patients. I would argue, even if you are in a remote area and you have a very, very good scan and you're comfortable with your reading, CT scan, then I might also say that you could treat those patients. It's off-label now, but try to give patients a chance.
If the patient have minor symptoms but disabling for the patient.
Yeah. Minor disabling should be treated. Minor disabling should be treated, and as I show you in the meta-analysis, even lower NIH stroke scale, less than 5, they benefit from TPA. But if they have minor non-disabling, it's advised not to treat those patients because 85% of them, they will do well anyhow. But you should admit those patients and have maximum medical therapy.
If we have patient with suspected infective endocarditis, how can we rule out about infective endocarditis? Is this, if we have patient cardiac already and they come for us?
Right. Infective endocarditis is one of the relative contraindications that's still there, and I wouldn't advocate to use TPA if you have high clinical suspicion of infective endocarditis. And what I mean by high is somebody who's febrile, and if you auscultate, there is a murmur, you can have an echo in the emergency and they can look for their hearts and see if there is any vegetation. If they have infective endocarditis, then the treatment is antibiotics, because this is a white WBCs, it's an infective clot, so TPA might not offer anything, and it can be harmful if they have mycotic aneurysms. A lot of time they have multiple infarcts, so they tend to bleed. So TPA is contraindicated if you have an infective endocarditis.
There is some question, TPA effective for lacunar stroke or not?
Yes, it's effective in all type of stroke, and there has been data looking into the lacunar stroke in particular, and they did better with TPA on top of that. And as I mentioned, a lot of time when we see the patients, you don't know what's the pathophysiology initially. So you need to treat the patients no matter what you think their underlying stroke etiology.
What's your recommendation in era of COVID now? If we have patient with acute stroke, what's your...
We still, patients with acute strokes, even if they're, sometimes we don't get the results of COVID until late, but they should be dealt as like non-COVID stroke, but you take a precaution. As I mentioned, if you have access to TNK, it might offer an advantage because they don't need to put the infusion. They don't, if you are transferring patients. But still, I mean, if patient is eligible and you suspect COVID, he should be treated with IV TPA or mechanical thrombectomy likely. So we perform mechanical thrombectomy. You've done thrombolysis to COVID patient as well.
As a patient with a ischemic stroke, you see patient COVID positive, can young or old age or medium?
We've seen all the, we've seen stroke, what we think is stroke due to COVID. This is typically patients who don't have risk factors and usually younger with large clots in their vessels. But we've seen strokes associated with COVID. This is typically somebody who's elderly and they have risk factors, and they just had COVID in addition to, they just had the stroke in addition to all the complications. So you've seen all the flavors and the spectrum of that. But alhamdulillah, now the numbers are decreasing than what it was a few months ago.
Thank you.
And by the way, in an international study we participated on, initially they said that the stroke occurs in 5% of patients with COVID. This was the Chinese data. But the global data, it shows it's around 1% or even less. So it's not as high as what we think earlier. Okay. Thank you very much, Dr. Adil. I'm very eager to hear Dr. Sultan. I don't want to take much of his time. So thank you for having me.
Next lecture with Dr. Sultan Al-Qahtani, interventional neuroradiology, our expertise in SCGH neuroradiology. He is fellowship in neuroradiology, interventional neuroradiology from McGill University, Canada, 2002. Canadian Board Subspecialty Neuroradiology, Interventional Neuroradiology, Radiology Resident from McGill University, Canada, and he is currently associated with SCGH Riyadh as a part-time consultant in neurointervention, chairman and subspecialty consultant at Department of Interventional Diagnostic Neuroradiology at King Fahd Medical City and Riyadh. He is extremely renowned consultant surgeon in KSA. We can start with Dr. Sultan Al-Qahtani.
Assalamu alaikum.
Assalamu alaikum.
It's a pleasure in having me, Dr. Adil, and the group, and it's a real pleasure joining the speak and the group with Dr. Adil Al-Hazzani. He's a great and long-time friend of mine, and I'm always learning from him every day, considering the stroke management. I'll update you with the recent advances in the interventional approach to patients with acute stroke In fact, Dr. Adel has mentioned that the stroke divided to two parts, and clearly mentioning that the acute ischemic stroke is the leading cause of disability in adult people. And considering the impact of such a disease, we will be so happy as long as we see more centers in our region in the Middle East, and in particular Kingdom of Saudi Arabia, credentialed as stroke centers. I am happy to be part of King Fahd Medical City, which is recognized as a comprehensive stroke center, and is a GCI accredited stroke management center. This is center on KFMC, which is going to be recently opened, hopefully. Stroke coded is something that we're all excited about, and it's affect both the field of stroke neurology and the interventional neuroradiologist. And for the last 20 years of the world of neurointervention practice I had, we used to be a little far from the stroke neurologist communication, since the practice that we used to have is with the neurosurgery. We are dealing with a hemorrhagic stroke, the AVMs, bleeding, aneurysm ruptures, and some elective neurovascular cases. However, the gap between us and the stroke neurology has approximated, and we are becoming closer and closer. And nowadays, fortunately, we are start to know each other more and more, especially at night. So that's something we are happy about. So the stroke code has been initiated, and all acute ischemic strokes and acute hemorrhagic stroke should be and must be accepted unconditionally and managed accordingly. So there is a huge impact of ethics and guidelines to impact the practice on regarding these cases. All acute ischemic stroke will go through a stroke screening process from the AR, and stroke code will be activated immediately. And these patients have their own pathways for the appropriate abrupt management. As clearly said by Dr. Adel, that these patients are receiving the best management and the best outcome with the early intervention. And this is our center, me and Dr. Fahmi, who is a long time friend of mine, and we start to talk after the procedure rather than before. So that's the case we just did, and the patient did very well, so we can talk. So before, we have no experiencing any side talk in the corridors. This is the Angie Suite. Every center accredited. Usually you should have all the right equipment, right people, right pathways. So this is the stroke code management from before the patient arrival to the hospital. This center should be accredited and known even to the 911 mapping delivery system to the ER, so they know the closest center that could provide the immediate care of the patient. In some areas in the world, like in Calgary and areas in US and Germany, there is always a CT scan within the ambulance, so they can screen the patient before arrival to the hospital, and they could start the early management. Regarding the early management, I do prefer, and the data has clearly shown lately that the earlier the better regarding the IVTP, even with the large vessel occlusion, LVOs. If the patient received the TBA, is more likely to have a better outcome even with the mechanical thrombectomy. So whenever I hear the news that the patient had received TBA and the patient is still within the window of mechanical thrombectomy, I feel more optimistic and have better outcomes. So there are fundamentals in acute management of interventional stroke. So especially in an area where we are ready to face this, there is a specialty growth. There is more demand for trainee to go on this pipeline for the specialty, since we used to count that one neurointerventionist is enough for 1 million population. So the demand for this kind of people is more and more. So I think we are doubling almost every 5 years. So every 5 years, expect to increase the number of neurointerventionists for each million. So once we used to have 1 per million, after 5 years, 2 per million, after three per million, since the awareness of the publics and the centers are grown to face the needs for the interventionalists. Are we full in Saudi Arabia, for example? We have approximately 25 neurointerventionists in the country. Are we really facing and treating all the patients in need for us? As mentioned in the data shows that we are not even treating the 5%, maybe at the 3.3% we are treating this kind of patient. Imagine how many patients still left alone. In KFMC or in my center, we are almost treating 150 per year. What does it mean? As a numbers reflection on 3 or 5%, I think we need, instead of 1.3%, we could treat 4,000 people. So imagine how much or how many we need to face this kind of problem. Research and development, I have seen a lot of patients. They are not fitting the guidelines that comes within the American Heart Association. In fact, the guidelines is more generic in my prospective analysis. So there are so much overlap between the patient and indications. Yes, these indications for treatment should be fully respected. However, having all the dedication and application of this guide in our environment is, we have to be always very careful, because there are patients who are having a different kind of pathology. For example, different pathology, different multiple strokes at the same time, recent multiple strokes, early and late, the impact of posterior circulation stroke. There is huge homework need to be done from our societies as well. System integration, the maturity of the system or healthcare system is a national mission, is a national organization which involves so many things more than the healthcare. So they have the traffic people. If there's a patient, for example, waiting for a stroke and he stopped in the traffic light, and there are people cannot cross the red light because of the 3,000 violation fees. That could impact the patient's outcome. So where we are in this subject. So there are so many integration needs to be matured in the system. Management and leadership, there is also a huge impact in getting these strokes management implemented in the institution. Leaders should create a list of priorities. Are these centers eligible versus non-eligibles, as clearly mentioned by Dr. Adel? People who are in Al Ghurayat or in Rafha or in the Jazan, how much we can help these people, how we can, since our country, alhamdulillah, is quite a huge geographic, how we can give this management and deliver to this patient appropriately and fairly, as opposed to those people who are close to the centers. Concept of training, you need to have more training system to build our national demands. It's not only in our country but also in the Middle East. So we just had recently the approval for the our fellowship in neurointerventional. So, but are we really enough? But I think I'm happy that it's a step forward that I'm sure, inshallah, it will help in getting people trained to face the demands. Financial support and sustainability, that's quite a huge impact. Is the government always need to support this kind of cases? I think it is something has the people's right to have them treated. We are happy now. We are treating patients in our institution regardless of their nationalities. We deliver all the stroke care to all citizens or expat in our institution unconditionally and free. That's what we really feel about and proud of. And society formation. Society formation is something that will create the connection, promote guidelines, promote the standards of care, promote the interaction between all specialties. And I think we are in need for creating more specialty dedicated for neurovascular specialties. Public awareness campaigns, these are fundamentals for people to learn. We learn a lot from unnecessary information in the daily media from those, they said, famous people in the media, and we know all their social and personal behavior, and how much we learn or heard about the necessity or the needs to have the stroke patient aware about their disease and what they should show immediately to do whenever someone face trouble. Industry and active involvement, always we always talk about the Western. We all talk about data from outside. It's always good. It's always something that we build our practice on. But really, we need to build our own. We need to have all our own recipes to be able to help these patients to the best interest of outcomes. Does everybody know treatment option for cerebrovascular disorders? It's endovascular versus open regarding the hemorrhagic, endovascular versus medical therapy or with medical therapy in ischemic. Availability of well-trained teams from both sides. Multidisciplinary approach is the key for success. Whenever there is a full integration, full mission for specialties, and everybody patient-centered to have the patient managed the best way, the success definitely happens. The proper management is a multidisciplinary team approach who can provide best option for each individual case. So each case should be discussed individually and guided by the appropriate guidelines as published. Acute ischemic stroke, as Dr. Adel mentioned, actually the number has estimated to be 20 millions rather than 15, as clearly mentioned by Dr. Adel. 5 millions are left permanently disabled, and stroke burden raised from approximately 38 daily in 1990 to 61 million disability active daily in 2020. And as mentioned, 1 out of people will have the stroke in their lifetime. Introduction to the ischemic stroke is very common, and the preference is in Saudi Arabia is almost 30 per 100,000. Limited availability of specialized centers which can treat is really a burden, and the second leading cause of death and the leading cause of disability. Time is brain, as mentioned. Urgent treatment of acute ischemic stroke is very crucial. Every minute pass in the untreated vessels, brain lesion, 1.5 million neuron dies, 3.8 million synapse dies, 12 kilometers of axonal fibers die. Each hour pass without treatment equal to 3.6 years of normal aging. Classical picture that we see every day from people who are treating endovascular stroke management. This is a patient who presented within 4.5 hours stroke. And this is one of the best. Actually, regardless the outcome or the feeling from the endovascular IVTBAs, I always face the viability and the easy removal of the clot whenever the patient is receiving IVTBA within the window. So combination of both within 4.5 hours is something really good. But again, the time is in our favor since we are reaching the 24 hours. We'll do now. Geographic is a real challenge to treat a patient, as I mentioned earlier, and the sooner the better. It's geographic distancing is something needs to be dealt with it and provide more appropriate plans to manage these patients actively. So now we have the telemedicine, telestroke, and hopefully soon the IA, artificial intelligence, in managing these patients remotely to have a fair game with these patients. The estimated population growth in Saudi Arabia is 2.5% every year, and there is a huge growth considering the actuarial growth of the patient versus the needs, as mentioned Dr. Saad. So I'll go with the history of interventional management. And as IVTBA has clearly shows the effect in 1995, we actually followed the IVTBAs not quite far. So in my mind, we start intra-arterial mechanical thrombectomy in 2000 in my practice, and this is the case who is a 10 years old boy who had severe headaches and collapse. And I was in fact doing my fellowship training, and this is in December 2000. And this patient is the son of a doctor in our hospital. They were skiing up north in Canada. So this patient had angiogram, and there are two angiograms merged together. This is the right internal carotid artery, and this is the left internal carotid artery. This is the anterior cerebral, and this is the left middle cerebral. This is the opposite side, but there is abnormal vessels here called the infraorbital optic anterior cerebral artery, or accessory infraoptic anterior cerebral artery, and there is an aneurysm, anterior communicating artery aneurysm. We elected to coil this, so we coiled it 20 years ago, and we managed to occlude the aneurysm, and eventually the accessory vessels has concluded. But at the end of the procedure, control angiogram shows abrupt occlusion of the MCA. And we did IVTBA during the procedure with the mechanical thrombectomy. We used the wire. We rotate the tip of the wire and make it like, it's a remote kind of approach. And we macerate the clot immediately with IVTBA. And the patient recovered completely without any deficit. So, regarding the intra-arterial mechanical thrombectomy start quite early enough, but still the data shows the maturity over time. So this is the young lady, and she had in 2008 aggressive symptoms, though the brain looks great and nothing is there in the CT scan. And there is questionable basilar thrombosis. In fact, the hyperdense sign is sometimes can be overlooked, but actually the clinical evaluation shows the patient is seriously ill and she's almost locked in. So we did immediate angiogram and showed distal basilar occlusion. Immediate thrombectomy and thrombolysis was performed, and she had a full recovery. I want to point out something: the patient sometimes shows the hyperintensities post IVTBA or mechanical thrombectomy, that there is hyperperfusion effect, which can be missed with interpretation of intercerebral hemorrhage. So this is not a hemorrhage. There is a integrity of the thalami bilaterally with no mass effect, and there is no dissection. The whole tissue appears to be integrated, and this is just hyperperfusion through the early breakage of blood-brain barrier, and it's usually reversible most of the time. This is the clot migrated to the left VCA. If you go back, you see the right VCA is recanalized, and the left VCA, there is a faint filling defect, but will not change this at that time, because the patient was very severely and there is no much to chase. But most of the time now, if you see this hyper dense clot, it's a clot freshly immersed and mixed with the contrast. So there is a huge contrast retained within the clot, and the next day CT scan, this clot has clearly completely dissolved. So since there is enough mental thrombolytics within the clots, the other thing, this is the old infarct, and the patient she had a full recovery. The guidelines, as clearly mentioned, should be respected and applied, and there is a significant overtime and update regarding the inclusion criteria for patients who are in need for either the intravenous or intra-arterial medications or intervention. I will not go through it, so this is clearly very important. Pre-hospital stroke management is a key to have the patient arrive as soon as possible, and these are the guidelines for the timing for the patient treatment, and earlier the better, and there is cutoffs. 60-minute initiation of IVTBAs, 45 minutes interpretation of neuroimaging. So the time is very clear, from 10 minutes back to 15 minutes to less than 15 minutes. And actually the door to time window, we reach up to 20% in our institution. And the more we organize our work, the more we can deliver the care to the patient appropriately. This is again review of the guidelines. I will not go very much, but I will direct the discussion regarding the mechanical thrombectomy. As I mentioned earlier, the combined IVTBA within the window with the mechanical thrombectomy is, for me, is the appropriate approach, and we have more appropriate favorable outcomes. And regarding the mechanical thrombectomy, we have two approaches now. We have the either aspiration or the stent retrieval. Regarding the aspiration catheters, it's much cheaper and should be the initial management of acute stroke. And if you pass it like 2-3 times and doesn't work, you can use a stent. So there is a significant cutoff and cost regarding the patient management. These are the recent and matured papers that promoted the high effect of intraarterial management of acute stroke. So these are the devices. We have a significant number of devices. I'm not here advocating any particular type, but I would start in my practice with the aspiration catheters to remove the clot, which works quite well. And the more fresh the clot, the earlier the removal. And then we could use the mechanical thrombectomy devices like the Solitaire or whatever device available. Regardless their manufacturer, unless you have some concern about your experience with each device. So everyone has the appropriate training to have these devices properly delivered and used. So I advocate that everyone who are doing endovascular management to have the appropriate training for each individual device. Sometimes the success and the delay of the procedure remain seriously on how much devices you are using and what's your experience and familiarity with this kind of tools. This case done within minutes. So with aspiration, simple aspiration, distal access catheter, sometimes balloon distal access catheter, and rest the flow, and just go to the M1 and aspirate it. Few minutes, patient back to normal based on the time of approach. 24 hours post onset is something that we are happy to achieve. And now we have patients who have left MCI stroke and fully recovered. He has 24 hours window. So this patient had complete recovery. So there is a significant factor which we know, like lateral formations, patient age, availability of healthy brain that sustain and have a more mature autoregularity system that sustain the clot. So the time is not only a limiting factor regarding the stroke management. However, the patient status before the stroke is very crucial in a patient's outcome. So there is a huge data that needs to be answered. And there is a huge room for, say, for example, long-standing smokers. Are they going to be benefit as non-smokers with respect to the same time effect of the stroke? I'm sure theoretically the healthy one will heal better. However, there is a huge math needs to be calculated regarding these patients. This is again Basel. People like Basel because it's very critical vessels, and I know we didn't apply the same guidelines. All guidelines presented now is for the anterior circulation. Posterior circulation, there is a huge discrepancy between the patients, timing and the progression of acute stroke. Some people are sustaining a stroke over 24 to 48 hours. And even I did 38 hours, in fact, and the patient has recovery. However, there are people who are suffered from early stroke within hours from the basal and still they die. So the posterior circulation is very critical. And I do prefer to do MRI and have diffusion, perfusion, mismatching. And if this happened and it's founded, I think this patient will have poor outcome if they are matched. The other disease causing stroke. This is a patient whom I encountered 2 months ago, and this patient had right MCA stroke, and every vessel imaging intracranially appears to be patent, and there are people could be missed in the pipeline, and they did angio for this guy, and shows a severe tight, nearly total occlusion or subtotal occlusion of the innominate trunk. And I barely passed with the wire. So I did just angioplasty and stenting of the innominate trunk. So this patient could stroke and kill his right arm, could have ischemic upper arm since the right innominate or the innominate trunk is severely tight. And in particular, whenever there is a lack of stealing phenomena from the left subclavian. This is a patient who is a 43 years old gentleman with recurrent right side stroke, and I did MRI for him. The CTA images shows everything is okay except for the left PCA questionable stenosis. So we did MRI and showed this is the posterolateral choroidal territories which affect the posterior arm of the cortical spinal tract. And I took patient to the MRI and we showed this hypointense acute ischemic stroke, the left posterolateral choroidal. I did the angiogram and shows very severe P2, P3 segment of the left PCA. Patient is not responding to the medical therapy, and actually we took him for angioplasty and stenting. And we crossed the P2, P3 and distal calcarine artery with the wire and the balloon the stenotic segment. And after balloon angioplasty, and we did control, there is a complete occlusion of the vessel. So we always keep the wire distal, and we deploy the stent along the included segment and the BCA disease with complete restoration of the flow. Clinically, our patient is doing fine. Regarding the concomitant lesion patient with acute ischemic stroke, and they having medical therapy, and subsequently patient recover, and we shouldn't leave this patient alone. So medical therapy and like the IVTBA and mechanical thrombectomy, you should evaluate this patient seriously to avoid any future stroke. In fact, what we see now, this is a patient who had left MCA acute stroke, and we did angio a couple of days later, and shows the left M1 distal severe stenosis. Regardless of the medication, now there is a significant stenosis which could bring patient back with acute stroke. So we did angioplasty for this case, and there is significant restoration of the flow to the disease segment. This patient already on Plavix and aspirin. So there is there is significant debate about when to start Plavix and aspirin post procedure. It depends on the size of the stroke, as most of the people knows. Left ICA mechanical thrombectomy and vessels occlusion is something we work on. So we evaluate the patient from the heart up, and this is the patient who have came with the left ICA stroke. And there is significant tortuosity on the left aortic arch. We looped in the heart and we went up with the distal access catheter, and we reached the proximal portion, and we did aspiration. We aspirated the clot and clearly restored the flow to the clinoid segment, and there is severe kink at the proximal origin of the left ICA. So the story become really complicated since there is severe stenosis, which probably or most likely the reason for the patient strokes and thrombosis. And in fact, aspiration, it doesn't work alone. So we did aspiration distally to the M1, and we did control. There is a good restoration of the flow. However, still there is clots within the within the distal M2 middle cerebral artery inferior segment. So we chased that with a small stent, and everything has completely removed and restored. And we went back and we did angioplasty of the kinked part of the left internal carotid artery and stenting as well. So this patient could have multiple procedures at the same time to minimize the risk of re-thrombosing or re-occlusion. Hemorrhagic stroke also can be related to vascular disease. I will just give some examples of hemorrhagic strokes. This patient who have a peripontine dural fistula and AVM, fistula to AVM in fact, and he presented with subarachnoid hemorrhage. He came with the symptoms and signs of subarachnoid hemorrhage. Actually, in fact, he came with also associated pica symptoms. We did an angiogram, and it shows the left peripontine medullary dural fistulous AVM, and we did complete embolization of this fistula by vertebral approaches, and has completely occluded, and the patient had good recovery. I will stop here, and we'll finish with this case. Stroke cannot be always the malignant M1, M2, MCA. It can be huge through circulation arrest of flow. This patient who came with the left ICA occlusion. In fact, the patient is quite dependent on the left ICA, and once we restore the flow, the whole both cerebral hemispheres are completely restored. With the complete recovery, since the patient came quite really early on time, because the symptom was abrupt and was very severe, and it's bilateral. Anterior cerebral stroke is not the common stroke that we see every day. However, this patient came with signs of left ACA strokes, and the angio shows the occlusion of the A2. Again, mechanical thrombectomy, you could reach now up to A2, A3s, and it can be restored. This patient have early ACA A2 segments, and in the other images show complete restoration. Mechanical thrombectomy with angioplasty is also the process. So I will not proceed much with the intraarterial, since it will take a long time, and I will end my talk now. I hope I did cover part of the endovascular management of acute ischemic stroke, and hopefully it is going to help for everyone, and I'll be happy to receive any questions. Thank you very much.
Thank you, our professor expert, Dr. Sultan Al-Qahtani. If there is any question for Dr. Sultan.
Good, no question.
Can our professor? If any patient have basilar artery occlusion, who patient with ischemic stroke candidate for the mechanical thrombectomy? You hear me, Dr. Sultan?
Yes. Can you repeat the question?
If patient with posterior circulation with basilar artery occlusion, who can and they have no large infarction from pontine or cerebral infarction, this patient candidate up till 24 hours, or there is any change?
Actually, generically, we could apply the same rule, but in fact, posterior circulation has different pathophysiology regarding responsive effect of the stroke on these kind of structures. So if the patient is still clinically well, they do well, in fact, post thrombectomy regardless the time. So I do prefer do imaging like CT, CTA primarily, then I do MRI and the MRI is usually better than the better than CT in evaluation the posterior circulation stroke, whether to go and proceed or not, since regarding the flare perfusion mismatch is existing or not. So I go always with the mechanical thrombectomy, but in fact, most of the patients who are sustained the severe stroke to the bones and the cerebellum, usually they don't do very well.
طب patient with wake up stroke يعني within 24 hours.
Again, we apply the same rules and the guidelines regarding with respect to the wake up stroke, and we consider the timing from the time patient last seen well, and if the patient is still within the window, we still go ahead. I rely more in the perfusion effect. We could do CT perfusion at the same time. If the patient is still having penumbra with the high reservoir, we still go ahead regardless of the timing. I think the dedication discussion case by case is very crucial with respect to the management of these patients.
في سؤال كده بس أول ما توصل الحالة الطوارئ البروسيجر. لا في سؤال تقريبا من يعني حد ممرضة أو حاجة زي كده، إيه البروسيدور بالنسبة للتمريض؟ يعني هو بيتكلموا على إيه اللي الممرضة تعمله.
Oh, there should be a stroke code guidelines within the whole hospital, and it's affect all the ER physicians, nurses, anesthesia, interventionist, stroke neurologist, and this patient can be even notifying the hospital before arrival. This as a stroke code, and the anesthesia, the nurses in the ER should be ready to face these cases and apply all the guideline tests and triaging this patient to go from the early biochemical clinical evaluation, biochemical, and send the patient for CT and CT scan and CTA of the carotid with the no waiting for any results of the urine and urea and creatinine. So this patient immediately post clinical evaluation in the ER and doing the blood test with drone. This patient immediately will be sent to the CT scan and CTA of the brain and the brain vessels. Okay, so the key message: don't wait for to have the contrast study. Patient will, okay.
Okay. If we have patient with large vessel occlusion, we can start by, as Dr. Adel Hazani mentioned, we can start with RTBA at the same time, followed by mechanical thrombectomy.
Yes, we could start IVTBA as long as the patient within the window, and always happy to have this news once the patient received IVTBA, even with the existence of large vessel occlusion. So they do even better once a patient combined, so had the IVTBA and the patient has mechanical thrombectomy. Because there are, to my mind, there are a significant amount of clots disseminated distally, and the existing IVTBA will take care of it, definitely.
طيب, with the era of COVID, what's the precaution we can
I think acute stroke will be, each patient who is unknown whether to be COVID or not, consider to be COVID patient with all the precaution to be taken. But however, the same pathway, the same protocol will be the same regarding the management.
Okay, thank you, Dr. Sultan.
Thanks.
أستاذ صالح.
ايوه دكتور تفضل الله يحييك.
Thank you for this.
هلا.
Thank you very much.
Thank you.
الله يحييك يا نفسك. You're welcome دكتور anytime.
Welcome دكتور.
Thank you دكتور سلطان.
Thank you.
Thank you, everyone.
Thank you.